Thank you, Chairpersons. Thank you, Dr. Sobha. Thanks, Rajalakshmi. Whenever there's a talk about retinopathy, I think Dr. Rajalakshmi did say that it's great that the physicians have started looking at the fundus, and then I have to remember this lady, and then everybody knows her as Dr. R.M.Mohan, and she was the one who was instrumental in, especially me, taking up diabetic retinopathy diagnosis very seriously way back in '88 when I was doing fellowship under Prof.Sobha Viswanathan. And not only that, those who took interest, she just made sure that some of us even went to Shankar Nethralaya and spent the evenings. And when I started my hospital for diabetes in Bangalore in 1990, I think I started with a fundus camera and FFAs, and we were trained enough to do FFAs, and we stayed away from the lasers. And this was in 90 because she was a very passionate person, and some of us were very passionate. So I very fondly remember her. And Dr. Mohan asked me, please include this slide in case if anybody wants to take the photograph. You are most welcome. Of course, the face of Dr. Nikhil would look the best if you want to take the photographs, but then you are most welcome to take the photographs. Now, coming to the question, why should physicians diagnose diabetic retinopathy, glaucoma and AMD when we have the means? Okay, I will answer this question in a slightly different way. Request you to just close your eyes for 3 seconds starting now and just see what it feels. Absolute darkness. All can open their eyes. Now, if this darkness is happening every 20 minutes to someone in the world going blind because of diabetic retinopathy, I think it becomes our duty to actually prevent this blindness. We will never be able to feel what the blindness is unless we close our eye and start walking. And that's when we realize what it is for a person who goes blind. And if we had picked up this particular problem earlier, we could have definitely saved the blindness. Now, just not diabetic retinopathy, that we also know the glaucoma and the AMD coexist in all the patients, and together they can lead to blindness. So, if you are a doctor and if you are treating any person with diabetes, then you screen for complications and you prevent blindness. And the onus is now on us because they come to us first. And this is the global estimation. You don't have to go into the data and the statistics and things like that, but 1.7 million people. And this is some more data from India, 21 million people blind. And people take glaucoma very lightly, and then this is the data, 12.8%, 1.2 million blind because of glaucoma. And nothing can change. You spend crores of rupees, they're not going to get back their thing. And we don't have too much of data on the AMD, and then I request Dr. Mohan's group to actually start collecting the data on AMD and then try to see how much of AMD are we really picking up in our diabetic clinics. Right. 101 million people diabetics, we know that's the data coming from the ICMR study. We know that diabetic retinopathy, glaucoma and AMD coexist together. DR can actually lead to increased IOP, disrupt the trabecular flow, and then it can cause the neovascular glaucoma. And the early detection and probably the coexisting eye pathologies will help us actually either to treat right early or then to refer them. So you as a physician, ladies and gentlemen, must remember you are the first point of contact to the patient because it's very asymptomatic. So patients don't have any complaints related to their eye problems till it is too late. But they have come to you for treatment of diabetes, so you become the first contact. So the prevention of blindness actually starts with us who see this patient for the first time with diabetes. Now the next question, why were we all hesitating earlier, and why do we still continue to hesitate? Knowing fully well that we can prevent blindness and we can do something to the society, we can do something to this particular patient. It's very, very simple. We are not trained in ophthalmology. At MBBS level, the posting was only 1 week, and my DNB MD days, my posting was only about 2 weeks. The last thing that we wanted to do during our posting was to look at the lady postgraduate and to see how good looking she is. We didn't do anything much. We wasted a lot of time. And then when we were posted in NIMHANS, the professor used to tell us an undilated pupil, and then he would say, did you see this particular disc? Did you see the bulge in the disc? We could see nothing, but we nodded the head and say, yes, 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 we saw everything. Only when the seriousness came when I was doing the fellowship in diabetology, that's about it. And then the feeling that, okay, I can always refer the case. I mean, I know the importance, I'm going to refer the case. The problem of referrals, I'll come to it later. Some people say the equipment is expensive. Not anymore. 2.5 lakhs, you have the best fundus cameras. 10 to 15 seconds, you have the diagnosis. Third is an answer that most of us give. Why should I have to do this diagnosis? I don't treat anyway. Now, I ask my colleagues the same question. Do you treat an acute MI? Then why do you keep an ECG machine? If this is what that doctor says, okay, I don't treat anyway, why should I? I'll just refer. I said, why do you keep an ECG machine then? There you save the life. Here you save the blindness. And the important part also is the patients have absolutely no complaints. So we take it absolutely very, very easy. Well, many places access to a retina specialist is a problem. We still have less than 2,500 people. And then when you refer a case, they need to travel to another different hospitals. Extra benefit, extra cost gets added up to them. And at one time, the fundus cameras were all mostly Japanese or German, very, very expensive, 18, 19 lakhs. I remember my first camera, Olympus, and then a Kova was costing almost 18 to 20 lakhs. Now you have everything for under 3 lakhs. And more than 70% of the patients are just not screened because they have to travel to an ophthalmologist. They tell you they will go, but they will never go because it's an additional cost to the patient. So my thing is, if the physician like you and me do not screen for ocular diseases during a routine diabetes care, when we can do all other things, the patient will go blind. Now look at this. Everybody asks the question, now what do I do? Let's say I pick up diabetic retinopathy, I pick up glaucoma, AMD. Now what am I doing as a physician? First, you pick it up. It is asymptomatic. The patient is not going to complain about it. Early diagnosis, prevents the blindness. You know the data on the blindness. It can help in early referral. And if the patient is serious, he will immediately know. You show him the fundus picture of blood in his eye. Immediately he will run to the doctor to whom you referred. And the moment you show the fundus pictures of something wrong, the patients become serious. And that's pure psychology with our patients. Right? It's like my wife is no more, but whenever I was going home late and things like that, and then with friends and things like that, somebody would show the photograph of my wife and say that, oh, she just called, and then so suddenly the seriousness kind of comes. But here also, show them the fundus picture, show them that blood, the seriousness comes. Well, we know that you have the treatment for diabetic retinopathy. I don't have to go into the details because now that's done by the ophthalmologist. For glaucoma, we know there is treatment. And for AMD, we know that there is treatment. When we have treatment, whether I do it or someone else do it, I think it becomes our responsibility to pick it up at least and then tell the patient, bring in the seriousness so that you are a better doctor tomorrow. So, as a physician, you do this whether you treat or not to prevent blindness. Now, how will it help your practice? You know that diabetic retinopathy and then the nephropathy kind of coexist in majority of our patients. So the moment you pick up early signs of diabetic retinopathy, you can start the renal protection. You can tighten your glucose control, you can tighten the blood pressure control, you can start your EAs, ARBs, you can start fibrates because there is some data that the fibrates are known to reduce retinopathy risk, and helps in planning your diabetic medications. You can start using SGLT2s, you can stop TZDs if you are worried about DME, and then you can reconsider use of GLP-1 RA because there is some very doubtful doubts about semaglutide and retinopathy, but then we are all doing the trials, so we will see about that. But then you can also use ARDS2 medications for AMD. And there are a number of other things that you can use or your colleagues can use. And then you start developing a rapport between your ophthalmologist. If it's a hospital-based practice, then you can always refer to your department. If you're sitting in a single clinic, then you can also have a network of colleagues who can actually giving you the feedback. What else? For a physician, now this is the question. Most important, we started off by saying we are going to do it to prevent blindness. Yes, that is still our first thing. You start to give a comprehensive care, and every guideline today, starting from IDF to ADA to RSSDI to everybody is now talking about comprehensive care. Diabetes treatment is not just glucose control. It's renovascular and metabolic in nature, and then you have to start comprehensive care. And the moment you do that, the patient is satisfied. There is always that 10% of the patients, when you want to take a fundus photograph and get a diagnosis out of AI, you may be charging 500 rupees. He may still think that you want to do it to make money, but doesn't matter. It's going to prevent his blindness. Most thing is, at the end of the day, if you pick up a PDR, it's a sense of achievement. It's like getting your results, and then they are telling you that, okay, you have finished your MBBS or you have finished your MD or whatever it is. The sense of achievement, that happiness is tremendous when you pick up something and then tell a patient, look, I picked this up, you immediately go. And you always learn new things. That inquiring mind to learn new things has to start, and then you are now called a progressive doctor, because as you start doing new things, because every time when there is something new, you have a point of care device for picking up early CKD, you immediately pick it up because you want your patient to feel, oh, my doctor knows everything, he is keeping himself updated. So you feel that you are a progressive doctor. And some complain about the money. Trust me, the return on investment is so fast, it's going to be faster than your investment coming back from your ECG machine. And most importantly, you earn money, and it's through a noble cause. I don't think we should worry about it at all. Now, can AI help to provide comprehensive eye care? Yes, the answer is very, very there. We can include comprehensive diabetes screening for ocular diseases during very routine diabetes test. So we have the cost-effective solutions. I will just be talking about Remedios integrated solution, the fundus on phone NM, and the Medios AI, because we worked a lot on this from 2016 onwards, 2018-19 onwards. Dr.Rajalakshmi and Mohan's group has also helped do this. Today we have an offline, the first time in the world, in AI generates a referral reports in 10 seconds with an accuracy of 94 to 98%. It can be used anywhere, any place. You do not require power, you do not require Wi-Fi. It can give you the diagnosis. It's just a new iPhone. In fact, the Apple have started a lab just to integrate with the Remedio group. So you have three things: retinopathy, glaucoma, AMD, and a few more will be coming later. So I've already shown you this particular slide, and this is how the reports are going to come. It's an AI-based chronic retinal disease reduction thing. The question that comes is, how do I believe the AI? There's so much of validation that has gone in beyond that in the last 7 to 8 years. In fact, Dr. Rajalakshmi herself has done many validation studies. We did it in our hospitals in Bangalore, and every eye hospitals in India has probably done it. And these are some of the things that I have just listed here. And trust me, and this is only for diabetic retinopathy validation. Okay. Now coming to glaucoma, the basic problem of glaucoma is you don't have one single golden test for glaucoma. you do multiple tests. Now, when you use an AI, it outscores the combination of all these other tests. In fact, the AI diagnosis for glaucoma is something that's very, very good, and we don't even worry about it. And same thing for age-related macular degeneration. So we were curious, even though we were developing it in our hospitals and then we were working closely with the Remedio group and others, we were curious to know, I mean, do we really see all this in our day-to-day practice? With that 1.5 lakh patients over a period of time, we said, okay, we'll just take some data out. As expected, 1/3 was DR, about 7% AMD and 9% glaucoma, just from the data. So that tells us that it exists. If you think it doesn't exist, it's just because you have not tried for this. So when you just screen people using this AI and look for DR, AMD and glaucoma, 50% are positive for something or the other. And you don't have to treat, you can just show them and say that, okay, now you go. Now the next question is it approved? Yes. AI for DR screening is approved by Government of India. So it's the first and the only approved AI by CDSCO in India. It's approved all across Europe. Something made in India. So we should be very, very proud of it. And I'm sure Nikhil will be talking about the new AI that All India Institute is also likely to come out with the help of Government of India. So we'll have a lot of things coming out of India very, very shortly. And then Singapore, it's a very tough nut to crack. And Singapore government has approved the Remedio screening. Right. These are some of the studies done using the Medeos AI for DR detection. I will not be going into the details of this. And these are some of the studies for the glaucoma that has been published. And this is macular degeneration screening. And this is a slide that I was talking about, that number of tests for glaucoma, the AI scores over those multiple tests. And then if it happens in 10, 15, 20 seconds and you get a beautiful report, even if there are false positive, I don't say that there are no false positives. It can be there, but at least you pick it up, you tell a patient, then you start concentrating on that patient. If you try to put the entire load of your diabetic population onto the retina specialist or ophthalmologist, things are not going to happen at all. I think I will just skip this particular slide. The conclusion is very, very simple. 1 in 3 patients with diabetes have diabetic retinopathy. So it's my duty, your duty to diagnose it. 1 in 2 have either a referable DR, AMD or a glaucoma. And we have comprehensive artificial intelligence powered screening using Medeos AI that can help in early detection. And it has taken years of work, especially using the AI on the images. And physicians today, or any doctor treating diabetes, have to think beyond diabetic retinopathy, and we are going to do that. And the leverage technology like the Medeos AI should become a part of the regular screening. And I know Dr. Mohans has also been using, we have been using, and many others are using. Last 2 to 3 slides are going to be interesting. Can we predict heart attack looking at the fundus image? Now this is the question the whole world is asking. Okay, so took a lot of interest because I was basically going through this, especially what's there in yellow and green you can see. So we have actually started working with Medeos and Remedios and Jayadeva Institute of Cardiology, and then trying to see. It's not easy because you have to teach the AI to recognize the changes in the eye, and then it's constant. We have already fed about 80,000 data, but then we are nowhere near it because we know eyes are the windows to vascular health, and deep learning is trying to pick it up. There are 8 to 10 people literally working for 10 to 12 hours trying to feed the data and trying to see what changes they can pick up on the eye. Okay, every algorithm for DR is different, glaucoma is going to be different, etc. So this will happen someday, right? And coronary artery disease triaging from retina will happen one day. It will be able to tell us your coronary artery score or probably your heart attack risk better. But what is impressive is, I mean, I did send this to EASD, but then it just missed the bus because I just missed it by a few hours, late breaking thing. Picking up early CKD through retinal images, we are getting a sensitivity of about 82, 85. Looks interesting at this point of time. So that means God has created this eye and the retina in such a way, there are going to be changes with lot of things, it's not just DR. And I'm sure one day, I think it's going to be the real window, and then all the ophthalmologists will be treated like God. I'm sure that day will happen. So thank you very much, and this is the team, and then I just would like to thank each one of them. And most importantly, we started 2018 with my son was a part of it, so I didn't want to do it, so I requested Dr. Mohan and Dr. R.Rajalakshmi, and then my very, very sincere thanks to the two of them, because for first 2 to 3 years, the way in which the validation was done for AI, and Dr. Rajalakshmi is a very tough lady. I mean, she looks very, her face looks very like a very smiling face, no. But then she will not say an yes unless it's an absolute yes. Thank you so very much. So we look forward to listen to Dr. Nikhil to see